Good evening to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's discussion on case scenarios in managing drug allergy during pregnancy. With much pleasure and honor, let me welcome today's host, Dr. Vijay Varadh, sir. Sir is MBBS MD consultant allergist, pediatric pulmonologist, clinical immunologist, and consultant at Sai Allergy Asthma Eye Hospital, Saidri Hospital, Imamdar Multi Speciality Hospital, Pune Allergy Center. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, sir.
Thank you for the introduction, and thank you IGCP for providing the platform to discuss the new topics and always to educate to the community, our colleagues also about the different aspects of practice because a lot of things have changed. The changing scenario, the disease patterns have changed. So I will, for the today's session, I will like to welcome Dr. Ritu Santwani, madam. She's a very eminent personality. She's a very well-known gynecologist, obstetrician, infertility specialist, sexologist, and cosmetologist. She has done MBBS, MD, FICOG, FIAOG, AMR, COG, Art Singapore, and she's one of the leading gynecologist, keynote speaker, author, key opinion leader, top 50 influential doctors on social media, founder and CEO, 360 Degree Healthcare Studio, Director Sham Well Women Clinic, PTBC, co-founder MAM, board member of SDWC. So he is a very, uh, as I
Thank you
mentioned,
so much. That much is sufficient, more than sufficient. Yeah.
so 24 years of experience, and she has a very good 360-degree healthcare studio in Pune. And she had been a top asset with many most iconic women CEO award of the year, then MS Signature Award, then top social media healthcare educator award, and many more. So I will like to invite Dr. Ritu Santwani, ma'am. Ma'am, please,
Yeah.
you start
Yeah.
with questions and then
Yes,
we'll go
yes,
with
yes,
some.
yes, 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 yes. Thank you. Thank you so much, Dr. Bharat sir, for inviting me here. And thank you, IGCP and MedTalks. So today, as we know, we are going to discuss about a very important topic related to drug allergies during pregnancy. We being an obstetrician, once the patients are approaching to us, because already once the pregnancy is there, we know the immunity status is little down. And the patients who have already having a history of some or the other allergy, they are having a lot of confusion in their mind. Madam, is the pregnancy is going to aggravate my allergy symptoms? And there are different allergy symptoms, different kind of the allergies also reported. So today, now once you are with us, a master blaster for this subject. So really, sir, I am honored to be with you today regarding discussion of this topic. So now, as we obstetrician refer a lot of the patients of the allergy to the pulmonologist and the allergy specialist like you. So my first question comes to you, that what are the common type of the allergies what you usually see in your practice during pregnancy, for which you get a lot of reference?
Yes, ma'am. Actually, it's a very good question. Even in, I think, last talk also we discussed about the allergies and asthma, how they are changing in pregnancy. So it has been found that around 30% of the women have a significant allergy trigger as well as asthma trigger. And the most common is rhinosinusitis, asthma, urticaria, skin inflammations. They have been a priority. Then some of the mothers, I found that they develop a significant drug allergies. So I get a lot of referrals nowadays, and specifically post-COVID, we have seen a very significant upsurge in urticaria, eczema, and drug allergies in these patients. So during pregnancy, because of some or the other reason, when they require some infertility treatment and some medications has to be given, and then suddenly these patients are referred for a severe drug allergies. So as you rightly said, the allergy pattern changes because of the hormonal imbalances, and then they get triggered during the pregnancy because of that. So 30% of the women they have severe exacerbations. 30% may continue with the same asthma, rhinosinusitis, blockers nose, or skin problems, or food allergies or drug allergies. Food allergies still less as compared to the other, and 2% only, hardly 1 to 2%. but most of them have these problems. And then food intolerance increases during that, and they have more vomitings and GERD like symptoms and all those things.
So yeah,
Yes,
thank you so much, sir, for clarifying this. Yes, we are seeing a lot of patients of related to drug allergy these days. Sir, is there any diagnostic approach by what are the some tests for which by which we can confirm that it is a drug allergy, that these are the allergic reaction, not the adverse reaction of the drug? That is very common question because as you know, we both of us are practicing in Pune. If we give any drug, if patient is having any kind of the problem, first they Google and read and they tell us, ma'am, this is the adverse reaction, not the allergy. So I want
yes,
what are the confirmatory tests for that?
yes. Actually, as you rightly said, see, reactions to the medications can be adverse drug reactions and drug allergies. So the primary drug allergy is still very less. Otherwise, it is mostly a adverse drug reactions. So generally, how to differentiate that clinically? So drug allergies generally within 2 to 3 hours, the patient starts having a very significant pain in abdomen, colics, then breathing difficulty, then hypotension, giddiness. Such type of severe symptoms are there. Some of the patients have a urticaria, angioedema, stomach problems, diarrhea, vomiting, and all. That also can be in a mild to moderate drug allergy patients. Adverse drug reactions can be just temporarily, they subside very well, and the patient don't have that many severe reactions. So now it is most of the time with the proper history. So generally severe drug reactions or allergic reactions are IgA mediated. So immediately the patient has that, and it always requires a prior exposure in a IgA mediated cases. So like suppose a patient is admitted and he is given a ceftriaxone. Day 4, day 5, then he will have a severe reaction. Then it is a IgA mediated allergy. And
Correct.
those cases, suppose you are doing a histosalpingography or some procedures, and first time you are giving some dye and all, and if the patient has a reactions, it is a adverse drug reaction. But only thing is that practically both the things, the mast cells and the other inflammatory mediators are released. So for the treatment purpose, practically, the treatment may be the same. Only thing is IG mediated reactions. There are chances that next time after the exposure to that medication, the patient can have a very severe life-threatening, and the baby also can be affected because of that. Like for example, I will give a case. One homeopathic doctor, and her husband is also one of the neurosurgeon in one of the very good corporate hospital. And first episode of her severe drug allergy, she had anaphylaxis like symptoms and she lost that pregnancy also. And they were so scared next time that none of the gynecologists were ready to see her and to give her treatment because they were, I mean, even she had a COVID during that time and nobody treated with the paracetamol also. Nobody gave her because she had a multiple severe reactions because of the multiple drugs. So such type of cases are increasing because the overall sensitivity of the patient has increased. Then again, another case I remember, one of the very well-known corporate hospital, the woman had some infertility treatment going on, and she was detected some infection. For that, the IV taxine was given. So previously she has taken a oral cefotaxime. This time IV taxine was given, and she had a very severe anaphylaxis like reaction. So that way, practically both are important. Only thing is when there is a IgA mediated reaction with the prior exposure, it is life threatening to the mother also as well as to the baby, the complications of that. Yes, ma'am.
Yeah, very true. Yeah, thank you so much, sir, for sharing these cases also. Sir, I have seen recently a one case, the patient for the infertility treatment. Once the endometrial thickness is less, we usually give the estrogen tablets. So that of my patient, she is actually herself is a, biomedical engineer. So I advise her the estrogen tablet for 2 mg once morning, once night. So after a first tablet only, she called me, madam, I have taken the tablet, but I started lot of rashes. So I told her, no, then don't take. Maybe you are having a reaction. So we have changed the salt of the estrogen. As a lot of salts are available, estradiol, valerate, hemisuccinate, but somehow she is allergic to all the salts, because this is something very strange. The estrogen, the every female is having the hormone. In my this 24 years of practice, I have seen the first case for the estrogen allergy. So
Yes,
in
they
that,
are increasing. These cases are increasing. So not only during the pregnancy, even we are seeing a very young adolescent girls during the that menses time when the hormonal changes happen, having a significant atopic dermatitis. Typically, that
correct.
time their acne get aggravated, and
Mhm.
even not only that, a severe anaphylaxis. I am having at least 4 to 5 young girls when
Okay.
during the menses they have a significant anaphylaxis because of some or the other trigger, even exercise induced anaphylaxis during the menstrual period only. So there are multiple factors for that, and as I mentioned, the epigenetics has changed, so the sensitivity pattern has changed, and so these cases are going to increase. We have to be very careful. We take a lot of history for one patient. It takes around 2 to 3 hours to take a detailed family history, any childhood history of any allergies, because there is an allergic march. It has been found that most of these patients, some or the other in lifetime, they had some childhood asthma, rhinosinusitis, some ocular allergies or something, and the gut inflammation, which is because of the environmental allergens they are swallowed, they cause a gut mast cell and eosinophil sensitivity, and then it is just triggered by the hormonal changes or something or any medications those are given for the infertility or other things, any of the gynecological obstetrical things.
Correct.
So I always say
Correct.
like it's like a leakage. The leakage was already continued, and the rains will trigger it. So these patients, ideally, there has to be a coordination between the gynecologist and allergist, because gynecologists know the total history of the woman since many years and all. So we always talk to them also. We get a guidance from them, and then we manage that. Yes, ma'am.
Sir, and I'm going to ask you the one question. Once I posted the flyer of our program, lot of obstetricians have dropped me the inbox related to these two questions. Ki now you are interacting with the allergy specialist. Please let us know which allergy drugs are safe in the different trimesters of the pregnancy. So at least we can start the first initial treatment before we are referring the patient to you.
Yes, yes. Actually, see, uh, for the mother and for the baby purpose, both of them, during pregnancy, if any reaction happens, fexofenadine, levocetirizine, desloratadine, they are very safe. Only thing is that, as I mentioned now, because of the hypersensitivity of the mothers overall, they require a higher dose. Previously, like even the single dose or whatever the normal dose also used to be sufficient. But now these urticaria patients specifically, they are not sufficient with the same, like I suppose fexofenadine, 120 milligram. It is not controlling them. So we may require to increase the dose to 240, 360, 720 milligram. That is very safe. Other molecules like cetirizine or something, levocetirizine, we can't increase because the mother will have a sedation, and there are chances of
Correct.
accidental injuries and all. So
Yeah, yeah.
then better to go for the fexofenadine. Practically now, many of these resistant cases, I have used bilastine also, because rather than oral or parenteral steroids, we can't give during the pregnancy. It is not good to the mother because it has its own side effects. We all know steroids
Correct,
have a lot of.
correct.
So
Hmm.
then we have used the bilastine also, and we take
Okay,
a, bilastine has not been studied during the pregnancy, but overall it is very safe drug because it's non-blood-brain barrier crossing. It does not interfere with the liver or kidney, anything. So practically, I think it is a very safe during pregnancy also. So practically, we have used in many cases. Those cases where the fexofenadine is
so,
not
sir, for
working.
what doses you advise for this Belastin?
Bilastine basic 22 milligram dose generally
Okay.
during
Oh,
pregnancy. Other patients, adults, we increase up to 80 milligram, 160 milligram also. But
okay.
like hexofenadine, suppose I have given 240 milligram twice also,
Correct.
and the patient
Uh-huh.
is not having response. Then after 6 hours, we use a bilastine to control the urticaria symptoms. That, and
Correct.
even
Correct.
along with
Thank
that,
you.
we can use ice packs or something.
Yeah.
Some specialized
The
soothing,
symptomatic treatment also we have to start. Yeah. Yeah.
soothing lotions are there, like that also can be
Yeah.
used. There are some Ayurvedic
Correct.
also, some
Correct. Correct.
Alamine.
Correct. Correct. Yeah. Thank you so much, sir. Related to this, another question, as you have just now clarified about the pregnant ladies. Now, my next question comes, as a lot of doctors have asked me, related to this breastfeeding ladies. For this breastfeeding ladies, also, what you suggest? Which drugs are safe for during this period?
Yes, yes. Actually, uh, for the breastfeeding mothers, even fexofenadine, bilastine, desloratadine, levocetirizine, avastin, they are very safe because generally through the breast milk, these concentrations don't go to the baby because most of them, if you're looking at their pathophysiology, they are excreted to the stools of the mother or to the urine. So they don't cross the blood-brain barrier or they don't cross the even through the milk also, mother's milk also. They don't go to the baby, so they are safe, no problem.
Okay. Thank you.
Yes,
Thank you so much. Sir, I think we can go with some of your presentation. All are waiting for that. Some cases we
sure.
can discuss.
Yes,
Yeah.
yes. I will just highlight some of the things because actually,
Yes.
as a gynecologist, I can understand that you are so busy with so many procedures and cesarean and all. So there are many things which are changing into that. And
Correct.
the most important is that uh, generally, usually the physicians and case physicians and all, they are not trained in these specific situations. So what they do is that they
Correct.
use it according to the normal adult physicians with the nebulizations and paracords and all. And same way, drug allergy is itself a different specialization, and dermatologists also they will be scared to give any medications. So because most of the time patients coming to them, they have to use a local steroids and oral steroids. But as we know, the skin is the second mouth of the body. So even the localized steroids used can be absorbed to the mother's skin. They can be hazardous to the baby that way. So they should not use. And as a MBBS doctor also, some of these hidden signs should be picked up by the gynecologist. Why? Because it's not only the mother, even the baby is very important. After the baby is born, the baby is going to have a more severe allergies. And there are so many studies it has been found, and we are seeing now those mothers or the parents had a hidden allergies, maybe mild to moderate form. If they're not treated properly with the allergy testing and desensitization, their babies are now having a very severe eczema. I think as a gynecologist, you also must be finding a lot of
Correct.
children with the
Correct.
eczema on the cheeks
Yeah.
and all at the age of 1.5 months, 3 months,
Yeah.
coming to you along with the mothers, and the mothers also must be telling you, like my child is having such a rashes and all. So these cases have
Hmm.
increased, and then the milk allergy has increased a lot now. Even 1.5 months old child having a severe milk anaphylaxis, other lentils or soups and all when they are introduced at the age of 6 months and all. Now we are seeing a peanut allergy increase in India also. So why it is happening? Because the mothers are not treated properly. So it's not just symptomatically by the tablet form. I'm talking at the disease progress or immunological point of view. So these epigenetics which have changed and which is causing an immune dysregulation. And as the baby is born with the Th2 inflammation mode at birth, and if some of the precautions are not taken, like all we know now, a lot of cesarean deliveries have increased. The baby is not getting a vaginal flora and the artificial flora on the like skin as well as
Correct.
because of the procedure,
Hmm.
then some of the babies are admitted into the ICU, kept into the hospital. This pathological bacterial flora, they are again changing these things, and this Th2 inflammation is increasing. Okay, so these immunologic things are having a significant impact to the implantation, placentation, fetal growth. So even intrauterine sensitization is a concept. So last 4 years when I was working with the World Allergy Prevention Committee, how to prevent this severe atopic dermatitis food allergies into the next generation. So the gynecologists have a very bigger role. So not only just symptomatic management with urticaria, asthma or something, even for the development and fetal growth, and after the baby is born perinatally, how these babies can be prevented from these severe atopic dermatitis or food allergies, because once they have this, And as I mentioned, the sensitization happens from the intrauterine. They have a significant disease. IgEs, we have seen some of the babies of 6 months around 3,000, 3,500 total IgE. So the sensitization is happening from the intrauterine. So as a gynecologist, they should know like how this picture, and as we discuss about that, one third in your practice also nowadays, what do you feel like? How many cases must have increased like in your practice about allergy asthma patients?
I think earlier we are seeing this allergy asthma patient hardly means minimum 10 in a month. Now, to these patients are rapidly, I can say more than 20-25 patients are coming per month who are giving the history of this allergy, some or the other allergy. And we are seeing also the patients who are presenting us with lot of allergic reactions. As you clearly mentioned with urticaria, atopic dermatitis, lot of patients are coming.
Yes, ma'am. So that's why I said ki, like when I am getting such a, I am a tertiary place and I am getting so many referrals, like one, two patients in a week, I am getting a referral from gynecologist. So then definitely the cases must be more. So like this case, like second trimester, 38 weeker, we while undergoing cesarean, she had a severe breathlessness requiring intubation. And after some time, when the abdomen was getting like you do the dripping and
Mm.
cleaning of that as a gynecologist, and then she had a second very severe episode where she had a significant anaphylaxis again. So then the anesthetist suspected it, and then she was diagnosed as a betadine significant allergy. So when we took a detailed history, when the mother was referred to me, she had a sinusitis, seasonal childhood asthma, throat problems, and father had a snorer. First child had a seasonal cough cold. Then this was a severe drug reaction to the cefotaxime because of some procedure. Then this was a sopramycin. This was a patient from Mumbai, and she applied just a sopramycin over there at some lip. There was some wound or
Yeah.
something, and she had a significant anaphylaxis. After the treatment, she was referred to me. So these patients, the sensitivity is already there, and then the additives or preservatives into the even creams or any syrups or medications, the salts, preservatives, excipients, or additives, salts, as you like rightly said, the estrogen salt, even the different salts is getting triggered because the patient's sensitivity is only more. So these cases are increasing. Like this was a 32-year-old first trimester with itching and rash, and again aggravated during the pregnancy after the iron and calcium tablets. So this was patient from Singapore. So she had a nasal septums, and in between she had a urticaria 4 years back. It just subsided after a few months, and she had been here in India, and because of the dust and pollution, like Pune, now it's a number one in construction dust. Then
Correct.
number
Mhm.
one into the this one two wheelers that way. So again, the effects of anaphylaxis on the fetal oxygenation is very debilitating. Like so many abortions can happen and all. So again, accordingly, we have to decide and we have to manage these patients that way. Please,
Sir,
Ritu ma'am,
as you have
you
very
can ask the
rightly,
question.
sir, as you have, yeah, yeah. Sir, as you have very rightly mentioned related to this anaphylaxis, so yes, with the iron salts, we have seen a lot of patients are having the anaphylaxis. So as we know, that is mandatory because most of the patients we are getting anemic. So some patients with now the recent preparations what have come with that it is little less, but earlier what we have used the iron dextran, injector with that a lot of patients are having the allergy. So
Yes,
my next question to you. See, suppose if we are seeing the patient in the OPD with the severe anaphylaxis, so what are the steps to manage these patients?
yes, ma'am, absolutely. Even like in Bangalore, there was a CEO of one of the very well-known company, and
Okay.
during the just that procedure of uh, diagnosing, like some dye was given, and she died on the table only during the procedure. So these cases are already increasing, and specifically we have to keep in the mind once we suspect an like anaphylaxis, always use the intramuscular adrenaline. That is the best thing. Now I will always suggest
Okay.
that in your OPDs and in the OT also, please keep zero point 0.5 ml two syringes pre-filled, normal adrenaline, whatever we have, because in India we don't have EpiPen. So just keep it, label it, which date we have prepared it, keep it into the freeze. When the color changes, then change it. But always keep these two available in the OPDs, and because you may be doing some of the procedures. Because we have
Correct.
seen like some of the metals also triggering the anaphylaxis while examining and something. Even my spouse, Dr. Ushali, who is an ocular allergy, and we have seen like the when she was doing some procedure into the eyes and she put some lignocaine eye drops, the patient had anaphylaxis even with the eye drops lignocaine. So imagine the sensitivity has increased. So here, always position to the left side to avoid compression on the vessels of the gravid uterus, maintaining the adequate enteroplacental perfusion, systolic blood pressure more than 90 millimeter, and monitoring the fetal heart rate status. But adrenaline is the drug of choice basically, and then we can always it requires a team, so there is always an anesthetist and all. Call them and do the rest of the. Then anti-allergic medications, as we already discussed about the which antihistaminics are safe rather
Yeah,
than giving.
yeah.
If you give a even in acute case, the CPM also can be given, but the mother should be kept under observation because they will be having a sedation that way. So these are the
Sedation, yeah.
steps we should be prepared, man. Yes, ma'am.
Sir, I want to know related to the some recent tests, and because once we are referring to you the patients for the allergy, so usually basically the first patient are that what are the allergy tests you are going to do, or what are the allergy tests the doctor was going to advise me, doctor will advise me, and how many tests we have to do, and after how many days we are getting the results. So there
Yes,
are some
ma'am.
special tests what we are doing because we gynecologists are not very much aware about that test. So I want that everyone should be get benefited.
Yes, ma'am. Actually, it's a very good, important practical question because previously we used to do 200, 300 allergen testing, even drugs also 25 to 30 drug allergy tests and all. But now, practically, it has been found that the drug allergy tests are not needed also. Very few patients they require a actual drug allergy test because once we know that, suppose amoxicillin or some cefotaxime was given and the patient has reacted, ceftriaxone, he is already allergic to that drug. So there is no need to do the testing. Only thing is that why he reacted so aggressively because his already sensitivity was more. So the primary allergens like pollens, dust mites, animal dander, insects. Because I had a patient from Koregaon Park and she had a significant sensitivity. So it was a dog in her house. She used to uh, get the dog on the sofa, on the bed, and all. So she was sensitive to that and significant. And then the medications just triggered it. So these are swallowed also, they cause a gut inflammation, and the oral tablets and all they can cause a problem, as well as the overall sensitivity of the body increases. Once the patient reaches to that threshold, then they get a trigger because of these drugs. So many of the patients, the primary allergen testing also like per allergen 100 rupees is the cost. So depending on that, it's around 45 to 65 allergens we can check it depending on the exposure of the patient, environmental thing, air conditioning use, the funguses, or that way, or any pet exposure or something. Then drug allergies, which patients we want to do the drug allergies, where suppose you want to continue the same medication, whatever, like some hormonal treatment is going on or something, and you can't escape because of that medication, then we admit the patient, we do the skin prick test, maybe the epidermal painless bloodless. If it is not positive, then we do the intradermal test. Then, if it is a contact allergen because of the some of the medication touching or exposure to the skin and all, contact dermatitis, urticaria, then we can do the patch test also, and we diagnose that
Right.
which is type of allergy testing is there, and then accordingly we guide the patients that way.
So, sir, usually these test reports come after how many days?
Yeah, immediately. See, generally, skin prick test intradermal testing is within half an hour to 40 minutes. Patch testing, first analysis is within 6 to 8 hours. Then we call the patient after 24 hours, then 72 hours. And some of the patient have a late phase reaction after 6 to 8 days. So sometimes we have to call them after 6 to 8 days. The patch is kept out there.
Okay, okay.
Yes,
And
ma'am.
sir, is these tests are very costly?
No, ma'am. Actually, as I mentioned, the skin prick test is hardly 100 rupees per allergen. So depending on that
Oh,
4,500, 6,500, or 8,500. And drug allergy test, suppose it requires a really drug testing. it is 300 rupees per drug basically. So they are very
Oh,
cost effective as compared to. Yes.
okay, okay. So, very nicely, sir, you have covered all the things, whatever the queries what we are having. Sir, my last question to you, as we have completely, properly on the time. Sir, my last question to you, sir, is it like that, that if some patient has given us the history that, madam, in last pregnancy, I am having lot of urticaria, atopic dermatitis, or the severe rhinitis as soon as my pregnancy is diagnosed, and I was continuously on the medications. So is it something like that, that before planning for the next pregnancy, so we can do something, some test or some medication we can advise her?
Yes, ma'am. Actually, basically, as I mentioned, the sensitivity during the pregnancy of these patients get triggered because the primary already they have a sensitization to these aeroallergens or some foods or something. Food allergy is still very less. 95 to 98% is the aeroallergens or environmental allergens like dust mites, pollens, and all. So we examine the patient clinically. We see the hidden signs of allergy like turbinate hypertrophy, posterior pharyngeal hyperplasia, long eyelashes, denim organ folds under the eyes. Like this habit, they cause a derriere line on the nose. So such type of hidden signs, then family history, the complete any childhood family or the same patient, if any allergen march or some history was there in between eczemas or something. And then we analyze and we do this specific test. Then we guide the patient on that. We reduce their primary sensitivity. And suppose there was a significant some medication or something during that pregnancy, we try to avoid and we give a substitute of other medications. Suppose like some texifotaxine or penicillin was there.
Correct.
So then we guide the patient or we talk to the gynecologist also. Any other substitute antibiotics also can be given to these patients. And most important that as a gynecologist, as I mentioned, our aim is should be to prevent the severe allergies to the next generation. So even the allergen immunotherapy before the pregnancy, if it is continued to these mothers with the proper environmental control, then some of the diets, then some of the biologics are very well, like this homeopathic doctor, as I mentioned. Before the next pregnancy, second pregnancy, we use the omalizumab, her monthly for 6 to 8 months. Her sensitivity went down and she tolerated the medications also. She tolerated the antibiotics during the pregnancy, IV fluids and all. Very rarely, some of the patients require immunosuppressants. They may have a side effects. So we have to be very careful. And there, these biologics are playing a very important role along with the probiotics. Even there are some studies where during the third trimester, if the mothers are given a proper probiotics, even the babies may not have a severe allergies into the food allergies and atopic dermatitis into the next generation. So we should have the charts in our OPDs as a gynecologist and how what type of procedures and where the patients can be risked. And as I mentioned, the hidden signs of allergy should be always looked, and these allergens history can be taken properly. And as we discussed, the standardized skin prick test is much better than the blood allergy test. So many advisors are done 22,000, 28,000 allergy testing and all. They are not much useful in most of the patients. The skin prick test, very few patients, if they have a real food allergy anaphylaxis, then this component resolved diagnosis now we are doing for the
Okay.
different foods and latex and these insects
Correct.
and all, and examine with that. And then some of the patients now the future is on the interleukins. So we did a studies in Pune. So in USA and all they are doing these interleukin profiles. And as you rightly asked about the question, these biomarkers can really help to prevent this allergic march and the complications into the next generation, basically. Yes.
Yeah, thank you. Thank you so much for very rightly you have clarified all the things. Sir,
Yes.
one more query I'm having. Is it any role of the nutraceuticals in the prevention, like vitamin C, vitamin E, are having any role? Uh,
Yes, ma'am. It's a very nice question. As I mentioned one of the slide, now already time is over. That's why we did not discuss in next some
yeah,
time. But there are these antioxidants and the inflammatory control medications are required because a lot of pesticides are used by the farmers. So nutrition wise, we are not getting the required antioxidant and inflammatory control. So vitamin C, vitamin E, as well as zinc, then like selenium, then quercetin, curcumin, colostrum. these play a very important role, and these can be a really game changers like probiotics and nutrition, and the future will be on that basically rather than treating the patients, how to prevent these severe complications.
Correct, correct.
Yes,
So
ma'am.
thank you so much for sir for enlightening all of us related to this very I think a very much needed topic for all the obstetricians and gynecologists as everyone is having lot of queries.
Yes,
So
ma'am.
thank you once again.
Thank
I
you,
think
Ritima.
with
Really, you spent the time and you gave us a time for us to discuss about the things. And every pregnancy is unique, so each and every person is different. So if we combine together as a gynecologist, as the pediatricians, even I will suggest ki, like the pediatrician also should be involved as the parents are registered with the gynecologist, because now the pediatricians have been really educated about the prevention of these allergies and all, and the anesthetist and the allergist should combine, and we can prevent these complications into the these patients also and to the next generation also that way. Thanks a lot, ma'am.
thank you so much. So I think with this we can wind up for the program for the today. So thank you
Yes,
everyone for the joining and thank you once again, Vijay for inviting me here.
thank you,
Good night,
IGC.
everyone. Good
Yes,
night,
good night.
everyone, and happy Ganesh festival. गणपती बाप्पा येतात आता परवा, तर सगळ्यांना खूप खूप शुभेच्छा.
Yes, ma'am. Same to you.
चल, या,
Thank you.
बाय बाय, गुड नाईट.